Hi, everybody, and it's another episode. Before you turn around, it's another every other Thursday, and we've got another Dentistry Beyond the Numbers. Wow. Really got a great response from the last one talking about treatment plan. Because let's face it, if we don't communicate to our patients what they need, if we don't explain to them what they need to go through, explain to them how to do it, explain to them what happens if, God forbid, they don't do it, and then go through line by line, we have no revenue. That's our bread and butter. Communication, as I keep hammering home, is the most important tool, I believe, in dentistry. I'm not a list reader. I'm not a money reader. I go through it empathetically with my patients, and we're going to get into that today in Dentistry Beyond the Numbers. Before we start, I wanted to tell you a few things. I really wanted to thank all of you for supporting me and listening and liking me. It's really been growing. I'm amazed at the growth and the reach out from people who really want to learn from me. And I really want to teach what I've learned and my experience through the years. Give me ideas of what you want to hear, you, the listener. A lot of young dentists have reached out to me and asked me for more treatment planning ideas. How do we sit and sell dentistry? I hope this helps you, because what we're going to do is sort of give you a roadmap. My goal tonight and today in this podcast of Dentistry Beyond the Numbers, thank you so much for listening, is to give you a simple roadmap that you can follow. Guidelines of treatment planning, which is the most important revenue generating aspect of our careers. Because you could have the best hands, A+ the entire academic 2 years of your dental school. But if you can't communicate, if you can't explain to the patient what you're going to do and how we're going to do it and what is going to be done, then you're not going to have any patients to do the work on. And that's the important thing here. So let me get into it. Last week, as you remember, we talked about the essence of treatment planning. And at the end, I broke it down into 4 simple stages. Today, I want to dissect those different aspects. Treatment planning, in my mind, is broken down into 4 legs, right? The first leg is tell the patient exactly what they need. Second leg is tell the patient what happens if they don't do it. And we're going to get into that one because that's the fear factor. That puts a little bit of the EBGBs in the patient, and they want to get the work done. Third is how easy it is, especially if you have repeat patients. We're going to get into that. And the fourth is send it and bring in the treatment coordinator. And whenever I discuss this topic, I always leave the treatment coordinator's duties out. Recently, I had a meeting with a bunch of treatment coordinators, and I realized that they need helping too. They go into the room, and we expect our treatment coordinator to answer all questions, do all things. We want to touch that tonight. So this is an action-packed, another one, Dentistry Beyond the Numbers. Really want to get into it because there's a lot to do. Number 1, tell them what they need. Well, I say our job is, as comprehensive dentists, is to go through all the pathology in the mouth. While going through the mouth, we're going to exactly depict different stages. We already know it. We've identified that with the hygienist, who's been amazingly, if the patient saw the hygienist already, pointing different things out that they want the doctor to check. If we didn't, we already viewed the x-rays. We know where we're going to go. So the problem is, for me and young docs out there, is a couple of things, pitfalls we're going to go through. But the most important thing is we're looking for comprehensive care. And while going through the entire mouth, we're going to explain to the patient what is going on and point out using the best photograph for treatment planning I know, and that is a panoramic x-ray. And what I'd like to do is bring up the panoramic x-ray. You see, here is a similar Panorex that we had last time. And ideally, you have a multitude of opportunities here. For instance, I look at this case, and if I see PAs and I see decay in the anterior, then I look at a full mouth roundhouse. I've got sinus problems to put implants. Is it worth the squeeze? Is it worth the effort to do sinus lifts bilaterally when we have such strong teeth? But the most important thing we're talking about is how to depict a case. I always start always start on the upper right. We talked about it last time. It's sort of like I go starting point, upper right. That's what I do. I'm a lefty. I start in the upper right. It doesn't matter if I'm the left side or the right side. Number one is always what I do. And I explain to the patient, this is your wisdom tooth. And because you're missing so many teeth, the teeth have been shifting. Your wisdom tooth is really not doing anything for you because it's not biting against anything. That's how elaborate I get explaining to the patient. I do not become mono-optic. Oh my God, look at that implant at 31 that I can do. Look at those laminates on 7 through 10. Man, I would love to take number 19 out. It looks like it's got a recurrent infection. I love extracting teeth and bone grafting. Great. But our job is not to do what we love. Our job is to do what the patient needs. We need to fill the void by loving everything we do. There are not many procedures in dentistry that I do not like to do. I like crowns. I like veneers. I like extractions. I like treatment planning. And tough cases, I like referring. But the number one thing is we have to go through the mouth empathetically. And this is where I see a lot of young docs go, all right, number one, extract. Number two, a root canal. Number three, we'll extract. Number five, crown. 6, crown. 7. The patient is apoplectic. The patient's sitting there going, this guy is just rattling off things in a car that he has to do or she has to do. As opposed to saying, you see this tooth up here, number one, we're going to take that out. Extract number one. Number two looks good, but you're missing a tooth. So we'd like to put a crown on here, connect it to here. So we're going to crown 3, add 4, and use 5 as a bridge. And this way, Mary, we're not going to have to do the surgery to raise the sinus. I think we're going to do great with bridges. Now, if we feel under other x-rays that number 3 is weak, I don't want to go into that right now. Of course, people will find that. I'm explaining to you tooth by tooth. 6 looks okay. 7, 8, 9, 10 look broken down. I suggest porcelain laminates because they're going to be beautiful and they're going to sustain some anterior chewing. You've been missing some teeth for a while. And then go through 13 and 14. I'd like to put another bridge there. I am not listing procedures for my staff to write down and then run an insurance report. We are saying it empathetically. Listen, perceived value starts with the doctor saying hello. Successful treatment plans are resting on the shoulders of the doctor. Because you could say your treatment plan coordinator didn't close it. And we're going to get into that. But if you're a doctor who really has trouble communicating and you're heard in the outside the operatory, 19 extract, bone graft, implant, instead of saying, Mary, this tooth has an infection. We're going to have to take it out. That takes you about 7 seconds more than just yelling it out. What I'm seeing is there's a certain level that some people are very much revenue generated. I should say revenue focused. It's great. But at some point, you need to remember every time that we're treating these wonderful patients. And it's sort of like being a rock star. These patients are coming to see you. The audience is coming to see the singer. What a great feeling it is that people travel to come and have us treat them. Let's not treat them as dollar signs. I always say, you do the right thing by these patients, the dollars will flow. The dollars will flow. If I explain to the patient what I just said, we're not going to do anything in the back, Mary. There's no need. Your teeth aren't hitting back there, and I don't think we need to replace it. And if we do, we'll look forward down the line. Follow those wins. That's a win. That's a win because the patient will say, wow, he's really good because he could have easily said, put another implant in, but he said there was no need. I really got to get this work done. To me, phase 1 sets the ground rules. I go through each tooth. I go through each procedure. I discuss it in less than a minute. And remember my thinking, okay? I always say this. When people are talking about, well, I'm too busy to do that. Okay, let's look at busy. I've got 32 teeth in the mouth. All right. We take a calculator, right? We have 32 teeth. How long does it take me to look at a tooth? I looked at a tooth. Less than 3 seconds. I could diagnose that tooth. Maybe 5 seconds. Okay. So 30 times 5 is 150 seconds. It's 2.5 minutes to go through the whole mouth. 2.5 minutes to devise a treatment plan, go through a whole mouth. Doctor, I'm not you. Well, that's what we aspire to do. We aspire to look at a mouth and know exactly where it's going. It'll take you time. It'll take you dedication. But at least you know that if you do the right thing, put the 3, 4, 5 minutes in to devising that treatment plan, then explaining it to your patient, you'll have a better success rate. And that's what we're seeking, a better success rate of committing patients to dentistry. Number 2 is really building a storyline, because then we're telling the patients, if they don't do the treatment, what happens? Let's talk about it. We must communicate to the patient why the treatment is not a choice. You go into an MD and they say, you have a blockage. You could either run it with Drano, or you can go in and get a surgery, or we have a medication. They're not giving you a multiple choice. What would you like? Would you like a removable, or would you like a fixed? I'm not a dentist that wants people to have options. They come to me for our experience and our knowledge. Whether we accept their insurance or not, that's secondary, doctors. If you live with the insurance world, you will muddle in the insurance world. Your job is to give the treatment plan. Let the treatment coordinator come to you and say, it's too expensive. Can we alter it? That's when we give them an alternative treatment plan. Before, let the treatment coordinator get up and say, listen, let me speak to the doctor. I'll be right back. But before that, I don't like giving treatment plan options. You could do this or you could do that, because you'll never do this. You'll always do that, because most people will look for the least invasive, least expensive. So what do we do when we're communicating? We describe to the patient, it's not an alternative, and to explain to the patient, like an example, what happens if I don't do the treatment? So again, I start in upper right. I say, this is what we need. If we don't take this tooth out, it's going to grow into the lower bone and cause a lot of unneeded pressure. But it's also going to could bring the bone complex down with it, which then means we're going to have an issue with the bone. My suggestion is take the tooth out, have no bite problems, no bone problems, and we're done with it. It's not helping the situation. Then I go to the bridge. What happens with the bridge? Now, I want you to notice the beauty of dentistry. Dentistry is the most beautiful profession, because if patients don't do it, it's not going to go away. It's not a cold. It's literally mechanical movement of teeth. And with that comes complexes of gums and bones. And with that comes problems. And Mary, if we don't do this now, as you can see, the space is closing. We are going to not be able to do it later, and you're going to lose multiple teeth, especially on the right side. And as we lose these back teeth, your front teeth are going to be asked to do things that they're not intended to do. Thus, they're going to start chewing, and slowly your front teeth are going to splay. They're going to separate. I don't want that, doctor. No, we're going to prevent that by giving you teeth to chew, giving you the foundation and the function that you need to be able to be excellent. And therefore, we're not going to have those issues. If you don't take the tooth out in the lower left, number 19, that has a furcation infection, it's going to start affecting the other teeth. Right now, we could take it out and the other teeth will last a long time. What I try to do, without putting too much fear, is put fear. Because dentistry, if the work is not done, it's only going to get worse. Our job in number 2 is to explain to the patient exactly what happens if they don't do it. And that is our bread and butter ticket to explaining to the patient how catastrophic their mouth can be if they don't do it. And that is the beauty of turning those patients into skeptics. So now we've set the tone. This is what we need to accomplish. We told them what happens if we don't accomplish this. Somebody may say, well, could we put a partial denture up there? You can, but eventually that partial denture will have hooks. And as the tooth moves and as the mouth chews, it's going to loosen up these molars. Therefore, we want to make sure that we're absolutely descriptive. We don't go into morbidity. We don't go into horror. We don't explain how bad it's going to get down the future. We explain to the patient in a very high-line form that not doing the root canal, not doing the extractions, not doing the fillings can only lead to more dental work. What's the third thing? Explain to them how easy it is. What does that mean? I mean, really, doc? I mean, this is extractions and bridges and pain, but I did the crown on the upper left. Maybe I did the crown on the upper right. Maybe I did work on the patient before. And I say to them, Mary, you remember when we did that filling? You remember when we did that treatment? Yes, doctor. That was the same injection I'm going to do when we do the extraction and bone grafting, when we do the bridge. You don't have anything to worry about from a fear factor. But doctor, it's expensive. Well, we're going to work out the best we can. We're going to get the treatment done. And when the treatment is done, it'll be done. You'll have a healthy mouth, a beautiful smile, and you'll have years of health in your mouth that you don't have to worry. All you'll do is come back for cleanings and recalls. This is the time. Having a healthy mouth now is like being tall young. You have a beautiful smile. I've alluded to this, that I had some work done on my smile. And I got to tell you, since I had that work done, I love dentistry more because it's given me so much more confidence, as I'm sure a lot of you. But we want to deliver that confidence to our patients. We want patients to know that the same numbness that we used to do the crown on the lower left is the same numbing device we're going to use to take the tooth out. And that's what I want the comfort to be. So if you have a patient that you've seen, a patient that you've really worked on a lot, then that patient is going to be easy to win over because they have your trust. It's the new patients where you have to say, did you ever have a filling? You obviously had crowns. You had some fillings. I mean, it's going to be painless injections. We're going to do the treatment and you are going to be extremely happy. Now, that sentiment needs to be transferred from the staff to the doctor to the assistant when they're taking x-rays. It needs to be upbeat, not negative. It needs to be upbeat, not negative. From the phone call to the appointment to the hygiene visit to the assistant to the doctor, and now we're at the treatment coordinator. That's called patient experience. We're looking for a 90% success rate in treatment planning. That's ridiculous, but it's able to be attained. And that's how you generate tremendous revenue, by successful treatment planning. There's no practice in the world that is going to be successful without fantastic sequencing of treatment plans and treatment plan acceptance. That's how it is. So then when we're done with our work, we want that patient wanting for treatment. I don't want to hear, well, what do I do next? I want to hear, when do we start? Because we've explained everything to that patient. And before I get up and say, let me get the treatment coordinator, let's make this thing happen in my mind, because I do not discuss money. And I do not discuss sequencing of cases. Just from a technical standpoint, I'll explain phase 1, phase 2. This is a perfect case because this is all phase 2. Very little, no decay, just things that have to be fixed and treated. Phase 2. We want our treatment coordinator to be able to discuss this. The fourth title, or the fourth tab in our treatment coordinating, treatment planning sector is get up and call the treatment coordinator. I like to call them the closer. Bring in Mariano. Here we are getting our treatment coordinator. By then, all the material, all the treatment planning is sent to the front desk. It's labeled on a treatment plan. The fees are put in. Our treatment planner, remember, is and will be the closer. We do stick around. We're in another room. We're in our office. We're walking around. We're doing an exam because there may be questions. There may be questions. But what's my treatment coordinator's job? I've often asked myself, what do I expect from a treatment coordinator? Number one, I expect them to go through the treatment plan one more time with the patient. Not as descriptive dentally as we did, but just make sure they understand, Dr. Liechtung has your treatment plan for the bridge on the upper right. He's going to be taking out that tooth. You have some work done, and he's going to do some bridge work on the upper left, and you have an infection in the lower left. You know all this. She goes, I do. Well, the total cost is $32,000. And I do not want my treatment planner to say, holy cow, it's $32,000. Because this should be humdrum for us. And it is, right? Patients come in, they get their work treatment planned, it's $32,000. And I just want them to know, we don't count anybody's money. The first question is, so Mary, after we go through, now it's $32,000, but I do want to explain certain things. If you don't know, they're going to first be putting in temporaries in the upper left. As they take out the lower left teeth, they're then going to work on the two bridges on the upper left and then move to the anterior. Just like that, to the front of the mouth. I want my treatment planning coordinator to know that much. What kind of crowns are they going to use? All porcelain. Using the best material, it's going to be beautiful. No metal. Oh, okay. Does it hurt? Well, the doctor explained it's like all other procedures. You're going to be very numb. I do not want my treatment planner coordinator to walk in and go, okay, it's $32,000. How would you like to pay for it? I don't feel that's a positive experience. I want that person to talk me through it. Mary, it's going to be excellent. I'm going to give you my card, my number's on it. What I would like to do today is, that is the big moment. Right there. Treatment planner coordinator goes over it, $32,000. What I'd like to do today is secure payment and scan or impress your mouth so we could start with study models and temporaries right away. That is commitment to dentistry. A commitment to dentistry is not, okay, I'm ready to do it. Let's make an appointment. Okay, we'll make an appointment. That's not a commitment. That's a call when she gets home and she talks to her loved ones and they say, Ma, $32,000, you got to get a second opinion. That second opinion might be cheaper, might be a denture, might not know what we know. Bottom line is, a commitment to dentistry means two things. Payment made, impressions taken. That's it. I don't care if it's an alginate that doesn't have any use. Throw it in the garbage. But commitment means those two things. Somebody asked me, how do you want them to pay? I like to make a payment for the case in full. This time, not next time. The only thing that's ever lost a patient, and you can devise this any which way you want, was really monetarily. If I can get the money out of the way and we're just talking dentistry, the likelihood is that patient's case is going to go very smoothly. What I'm looking for you to do is I'm looking for you to always focus on trying to acquire or trying to get full payment, 50%, but at least 20% of the case. So I'm asking for $6,000 and a scanned impressions or alginate impressions. Why the 20% and why the impressions? Well, I always believe that dentistry is a completely impulsive and compulsive type of situation. Somebody shows to you the mouth, you're not healthy, you have disease, you can look great, they show you pictures of before and after, you need it and you want it, so you decide to do it. But how many doctors out there have had their patients go home, talk to their husband, and their husband goes, what are you doing, man? This is 30 grand? Come on. I got cards to buy and this to buy. I got a golf club. I got clothes. Woman calls up and says, I think I was too ambitious. I think we have to break it down. Well, that's what happens. So it's very important to term a commitment to dentistry as a payment and an impression. I want to give you two scenarios. Patient made an appointment. Patient comes in, treatment plan done, same treatment plan I showed you, $32,000. The patient put down $6,000, took a scanned impression, put in models, told them we're going to mount the models so we know your bite. We're going to go to work. We're going to put temporaries on it. We're going to do all those great things. Thank you, Mary. It's a Wednesday. Friday, Mary calls up and says, I'm having a problem. My husband's angry. He wants the money back. He wants me. Well, Mary, we took a scan. We mounted the impressions. And, there is some money associated with that. So of this $6,000, there might be $1,500 or $1,750 or whatever we term that might not be involved in the refund because you took the impressions. And many times when the coordinator gets back on and explains that and say, Mary, look, this is going to get you healthy. Why don't you bring your husband in next time and let's talk to him, because this is the way to health and you need it done. Second scenario, I consider commitment to dentistry is just an appointment and a goodbye. So the woman in room 3 says to the treatment coordinator, I'm ready. I'm ready to make an appointment. And treatment coordinator is so happy she got something sold. No money transferred, no impressions. Patient leaves. We wave. We'll see you in 2 weeks. Patient doesn't show. Patient calls up and says, they decide, can you send their records to 123 Main Street? No connection. No connection. Even if they put their money down and called up, what are you telling them? Sure, we'll send you your money back. There's no commitment. There's no alginate. There's no scan. There's nothing. Nothing to keep that patient back in our practice. Commitment to dentistry means nothing less than the commitment to our practice. Impressions, if you do work, if you get them with the hygiene and a monetary commitment. Hopefully, when you're using third-party payment, you make one bulk payment. So they only get one bill. And by the way, we tell that to every one of our patients. When they want to pay as they go with third-party payment, we say, you're going to get 20 bills in a month. Do it once, get it over with, get one bill, and let us do your work. Like I said from the beginning, communication, essential. Essential. We're building a communicative professional. We're building somebody who can do all the things I talk about. The hamsa, right? The dental hamsa, the hand that has those 5 clear aligners, root canal, cosmetic crown and bridge, surgical extraction, bone grafting, and implants. That's my foundation. Being communicative, that's our legacy. That is what we build. We're getting knowledgeable and we're able to speak about it. That separates us from so many dentists out there. I'm not a guy who comes in and goes, hey, Mary, you need a couple of grounds. I take it like we're doing heart surgery. Because I feel that anytime we go into a patient, do invasive dentistry, numb them and drill on their teeth, we are treating a part of their body. I hold that in very high regard. And I think we as a profession and a professional, I said it, I say it to my son, the student, but I say it to every young doctor. What I love about dentistry is we are literally everything. Doctor, marketer, influencer, right? We want to go out and influence people to come to us. We got to carry ourselves a certain way. You've gone into a profession that is a hands-on profession. Remember that. How we act in public is how we act in public. And those are our potential patients. This is treatment planning, everybody. Treatment planning doesn't just come. Treatment planning is the mecca, the absolute most important aspect of our practice is to explain to our patients what they need, what happens if they don't do it, how easy it is to do, and then how we're going to pay for it. We know the doctor is extremely important, the hygienist, and we're going to get into hygiene. Hygiene is not just a byproduct. Hygiene is the product, because who's the first person our hygienists see? The new patients. Who are the first people our patients see? Our hygienist. That hygienist, we're going to go into it on another episode. They need to be positive about the doctor, upbeat about the team, loves the delivery of care, and tells that to the patient. Actually, treatment planning is such a team effort. And I always say it starts on the phone. They had it right. You got me at hello, right? You got me at hello. You call a practice and they go, yeah, this is ABC Dental. How can I help you? You're not feeling very comfortable. Hi, this is ABC Dental. Mary speaking. How can I help you? It's a different ballgame. It's all communication. And I think this is a very important aspect of us young dentists growing, us middle-aged dentists not sitting, not talking. I talk to a patient like I'm talking to you. Eye to eye, knee to knee, going through every tooth. 3 minutes later, I committed to a $32,000 case. And I'm going to go into the next room and do another one. It's a sequence. And that's how we're going to do it. Remember where you start, upper right. Remember where you end, lower right. So you have that roadmap. Thank you so much. Today was wonderful. I think we covered a revenue stream that is in your mouth, literally. It's how you talk to the patient. When the patient walks in, wave to them. If the patient sees one of your team members, tell them to say hello and smile. Treatment planning begins when they say hello. Remember that. It doesn't begin just when we put our eyes on them. They have already preconceived notion by the time they get to us. So I hope you gained something out of this today. In the next couple of weeks, we're going to interview some rock stars of dentistry, some people that have done so much in dentistry and then want to do more. We're also going to look for, in my opinion, that unbelievable dentist that has mastered the Hamsa. I'm looking for him or her. I know they're out there and I'm searching for them. It may take me a few more episodes. I'm narrowing it down. Trying not to keep it with my homeboy, because he's been with me for so long and it's easy, but he's definitely a consideration. And he knows who he is, so I'm not going to say anything. But I will say this. It's been a joy. This one will make you millions. This one will make you someone that can really feel confident that when you walk in a room, you can not only diagnose, but you can communicate it. And when you can communicate it, you'll be able to do it. Remember me, Dr. Marc Liechtung. I'll see you next time, and follow me on all your platforms. Tell me what you think. I want to know whether you think I'm great or you think I suck. I want to get better. Let me know, and let me know what interests you. We're going to be here, and we're going to keep going on Dentistry Beyond the Numbers. Thank you.